Hello, I'm David Deal. I'm a GCU student, and today you'll be listening to my research proposal for my professional capstone. Bear with me, there's going to be a lot of technical difficulties in this for a few different reasons. One, I'm used to presenting to an actual physical people. There's no one here, it's just me talking to a screen. And then I'm staring at my own face. So obviously that's going to come with its own challenges. Two, I'm using Zoom. It's the free version though, so I can't upload it to the cloud, but I can record the presentation, which what I'm doing, and then I will be screen sharing, ideally here in a moment, the PowerPoint with the instructor notes also listed so you can see all that additional work. You'll notice on the first slide, once we get started here, it'll just show video link in red. As soon as I'm done with this, I'll be uploading it to YouTube, getting that hyperlink, adding it to that slide deck there so that I can submit the slide deck to GCU. And then ideally, students, when we go to evaluate it, will be able to click on that link, go to YouTube, and then review the video. Uh, we'll see how it goes from there. So, without further ado, let us get into this. Share research proposal and share. Okay, ideally we're up and running. Okay, so for the introduction here, my research proposal is going to be for conducting study of treating post-traumatic stress disorder using psilocybin-assisted therapy. The reason for that, PTSD has changed significantly over the past, I mean, we're going on century here. In World War One, PTSD was referred to as shell shock. So even at that time, we understood that there were significant issues from people that face traumas, particularly in combat. That's changed over the years. We understand now that it can come from sexual violence, it can come from simply witnessing traumas and not being necessarily a part of it. And then it can come from repeated uh, traumas. For that reason, the population that I'm interested in for this study is going to be those that I've termed guardians. So it's not just veterans and it's not just first responders, but that group of people who intentionally put themselves in those potentially traumatic environments uh, for the sake of helping others. So for this, veterans, pretty common understanding of what that definition is. For first responders, I'll be including firefighters, law enforcement officers, medical technicians, that's EMTs and paramedics, as well as emergency room staff. The reason for this is that rates of PTSD, as far as the diagnosis goes throughout the lifetime, for the general population is anywhere between 7 to 12%, depending on which studies you're looking at. For law enforcement, after looking at numerous studies, it looks like it's going to be between 6 to 32% are diagnosed with PTSD at some point in their life. For firefighters, it's 17 to 32%. And for EMTs and paramedics, it can be anywhere between 9 to 22%. That's per Lewis Schroeder et al., 2019. And then veterans, per the National Center for PTSD 2025, shows that PTSD diagnoses can be anywhere between 3% and 29%. Of interesting note there, the 3% is for Korean veterans. And as we move through the eras, getting to more recent, such as like Operation Iraqi Freedom and all that, that's when we're starting to see that high 29% diagnosed. So I don't know what the change is, because if you look at other, actually, the National Center for PTSD states that the average is around 7% for all veterans, but it's highly concerning that there's such an increase as the eras progress to present day, from 3% to 29%. So continuing with the introduction here, the U.S. Department of Veteran Affairs, of all places, has actually been looking into the benefits of psychedelic assisted therapies for treating PTSD. They have a number of studies that they've reviewed, and currently they have a study with Yale and Brown University studying the effects of MDMA on treating PTSD. I'm interested though in the psilocybin component of it because it is very similar to MDMA, per Moreland and Woolley, 2024. Psilocybin has been effective in treating depression, anxiety, and substance use disorders. Uh, there is promising efficacy for the treatment of PTSD because many of those uh, are comorbidities with PTSD. Um, and part of the reason Moreland and Woolley believe that psilocybin assisted therapies could be effective in treating PTSD is because psilocybin's been known to create positive changes in personality. It enhances one's feeling of connectedness. It increases a person's openness, which is huge, especially for the veteran and first responder. You, I know there's some arguments between whether or not type A personalities exist or don't, but regardless, usually very strong personalities that are not super willing to ask for help. We're starting to see that beginning to shift now that academies at the very beginning of a lot of these careers are starting to push the importance of asking for help. But the fact that it has the ability to increase openness can help potentially solve that portion of that problem. Uh, Psilocybin has also been shown to be effective in facilitating fear attenuation and then induce emotional breakthroughs. As far as my research question here, it's pretty simple. Can PTSD be reduced or mitigated within the first responder and veteran populations with greater success than current practices through the use of psilocybin assisted therapies? Uh, I predict that not only will the effects of PTSD be reduced at greater rates, but there will also be positive effects on other mental health disorders that are associated with PTSD, such as depression, anxiety, and substance use. Uh, the way, the specific way that I'll be reviewing whether or not it's more effective is conducting a psilocybin assisted therapy in conjunction with cognitive behavioral therapy. And it's estimated based on Moreland and Woolley that it'll take approximately 60 to 90 therapy sessions with anywhere between 1 to 2 6 to 8 hour psilocybin administered sessions. So the literature review. Reviewing the efficacy of psychedelics by Muhammad et al. In 2022 expressed concerns for individuals who are not receptive to cognitive behavioral therapy, SSRIs, or prolonged exposure therapies solely. So just like in medicine, you probably hear me say this more than once. For instance, treating infections. Some people are allergic to penicillin. So now you've got to have a different one. Some people get infections that become resistant to other medications, so we need to have different options. That's what I liked about the Muhammad et al. Study, is that it did point out that the psilocybin assisted therapy might be an option for those who cognitive behavioral therapy just does not work. I do find it interesting. In my review, at least, it was very difficult to find what the actual efficacy rate is for cognitive behavioral therapy on PTSD. There was a few studies that showed that up to 50% of people simply are not receptive to it, but I couldn't find anything that showed what the positive results were. Ziff et al. 2022 explained that many of the newer studies are showing effectiveness when treating depression, addiction, and end-of-life mood disorders with psilocybin. And they noted the positive effects of it being very low risk for addiction. And then kind of just tangentially, if psilocybin has the ability to treat those things, which are usually linked with PTSD or at least comorbidities to PTSD, it stands to reason that it could also help treat PTSD. Um, but it does point out that psilocybin alone is likely never going to just be a wonder drug like here, just take some psilocybin and it's going to treat it. It is going to require pretty extensive therapies, as I mentioned earlier. And continuing with the literature review, I like the Keisley et al. 2023 article, which presented findings showing that MDMA and psilocybin assisted therapies had low certainty of evidence for being effective in treating PTSD. I put this one in there because obviously I'm biased to wanting to find something that is going to help PTSD, but you also have to be realistic. It simply might not work. So not to review or take into account studies that show that, well, maybe it's not going to be effective would be a disservice for the end goal of determining whether or not it is or is not effective in treating PTSD to help the population that I'm looking at. As far as the methods and data collections go, so the participants are going to be first responders and veterans with either a diagnosed or self-diagnosed PTSD. That'll either be generated whether or not it's the clinician administered PTSD scale for DSM-5, also known as CAPS-5, to measure PTSD, or if they take the PTSD checklist for the DSM-5 or PCL-5, which is a self assessment on PTSD. If I'm not mistaken, the CAPS is a 30 component assessment, whereas the PCL-5 is a 20 component assessment. The study will require in-person interviews and therapy sessions with clinicians, mainly because once the study is initiated, I do want to have a primary score per CAPS. I don't want to have any of the self assessments as part of it. I want it to be standardized throughout. So it will require the clinicians to administer the CAPS pre, post, and then ideally in a 12-month follow-up. And then it's also going to be required to have the clinicians for the actual cognitive behavioral therapy component of it, as well as the psilocybin administration. The control group will consist of veterans that are simply only going to receive the cognitive behavioral therapy. Again, I'm looking at the effects of psilocybin-assisted therapies, and I think it would be a disservice not to have a control group. But for this particular study, the psilocybin-assisted therapy will be psilocybin in conjunction with cognitive behavioral therapy, and then the control group will just be cognitive behavioral therapy. I think this is good because it has the potential to benefit both groups regardless. And then we can figure out in the end whether or not the psilocybin-assisted therapy is more effective or not. So for here, the dependent variable is going to be the CAPS-5 score. I'm sorry, the dependent variable is going to be the CAP-5 score, and the independent variable will be the psilocybin-assisted therapies. And then the dependent variable will be measuring it, like I said, post-study and then in a 12-month follow-up. And then I think the best course of action for this will be, or for analyzing the data, we'll be using a repeated measures ANOVA analysis, which will go into more detail on the next slide. As far as building the sample, it's not particularly going to be easy for a few reasons. One, most of the research I've looked at as far as psilocybin goes, the studies are usually very small, anywhere between 20 to 40 participants, and almost all of them in the future research suggest finding a larger sample size. For me, I'm going to be emphasizing pulling the sample from the California population. This for a few reasons. One, I'm personally familiar with California, and two, I'm professionally familiar with California as far as California firefighters, EMTs, paramedics, law enforcement officers in general, and then sheriffs as well. So because of that familiarity, I understand that there's things such as California Fire Chiefs Associations, California State Sheriff's Associations, the California Police Chiefs Association, and the California Ambulance Association. I plan on utilizing those as well as the VA within California for reaching out and requesting participants for this study, as well as contacting various academies for all those different agencies for the first responder side of the house, uh, because that's where we want to. One, that's where you usually send your best and brightest as far as faculty and staff, and then they've also usually do a good job of keeping their thumb on the pulse as far as uh, just newer studies and research into the mental health of first responders, because there is a recognized shortcoming, at least within the communities, uh, that mental health is a huge component to longevity within those fields. And then I believe that it'll be simpler than other studies to gain participants, uh, simply because, one, if it's through the VA, the veterans that we're reaching out to are used to a rank structure, and if someone of authority puts that out there that this could be a good option for them, they're going to be more receptive. And then as far as the first responders go, all those are paramilitary in rank structure. So by reaching out to those associations I was talking about and getting the chiefs on board, if they're on board with it and then they disseminate that down the chain, I have a feeling that we'll have a higher success rate for gaining participants. The other component too is simply these people are in these fields, and the reason they joined was to help others. So although there is the one benefit of them improving their PTSD or PTSD symptoms, two, by participating in the study, they could potentially be helping others that face issues with PTSD as well. So because of that guardian nature, that's going to potentially drive them to want to participate in this study as well. As far as the hypothetical findings go, I'll be honest, I was struggling with this. I reached out to Dr. G on doing this because it seems weird for a proposal for research to then have research. I get that it is an exercise now. He kind of explained that more to me. But I'll be honest, I'm a math guy, went through Calc A and B up through linear algebra, and then through the civil engineering field. But I'll tell you what, statistics is not. It's at least for me common sense math as far as application goes. Um, I, I I do know that SPSS is the gold standard, and I do enjoy working with Excel and databases and things of that nature. So at the very least, I believe I've nailed down what I'm going to need to use, which is going to be that repeated measures ANOVA. Uh, and then what I'll be planning on doing is using the CAPS-5 scores within subjects and then analyzing it from between the PAT group and then the control group, or just the cognitive behavioral therapy group. And then I expect that, based on everything I've seen with the psilocybin, that there is going to be a significant improvement to the CAP scores in the psilocybin assisted therapies opposed to just the cognitive behavioral therapy. And given the duration of those effects from psilocybin, I expect that 12-month is going to show the most significant variance between those two groups. And then what I plan on doing as far as utilizing SPSS, setting up the data is the easy part. So for the first column, it's just going to be the pretrial CAPS-5 scores that clinicians come up with. The second column is going to be the CAP scores immediately following the trial. And then the third score is going to be the scores at that 12-month follow-up. And then the fourth column is how we differentiate between. So it'll be, I mean, in SPSS, you just put ones for the PAT group and then twos for just the cognitive behavioral therapy group. And then from there, when we run the analysis, I can differentiate between groups from column 4, groups 1 and 2, or in this case, it'll be between the psilocybin assisted therapies and the control group. I would like to have a sample size of at least 100, and that would be all said and done past the 12-month mark. I know people are going to fall off, so the goal is to have more than 100. And then honestly, having never conducted any research like this or put out feelers to see who would want to participate in this, I don't know what the practicality is of actually even getting 100. That's why I narrowed my scope to just California as well. Trying to go worldwide or even just the United States, honestly, that's that's significantly above my competence, if you will, as far as what kind of sample sizes I could even achieve. As far as the future research goes, I'd like to determine the efficacy of psilocybin-assisted treatments in populations resistant to cognitive behavioral therapy alone, resistant to prolonged exposure therapies, and resistance to SSRIs or pharmacological um, medications, if you will, for treatment. I'd like to see whether or not there's a correlation between the reduction in PTSD due to psilocybin assisted therapies and suicidality. Do we see a decrease in suicide as we decrease PTSD? I would assume yes, but we can't make assumptions. I'd like to see a study on that. And then I'd also like to see if psilocybin assisted uh, therapy is applicable to other populations. Other research has shown issues, I think, specifically with cognitive behavioral therapy and those who experience childhood traumas. Um, uh, Correction, it's I've seen studies that show that psilocybin and the MDMA assisted therapies have shown potentially no improvements in PTSD for those with childhood traumas. So I'd like to see if that was a one-off or if we could determine whether or not it just isn't effective for that. Additionally, there's other groups such as sexual assault victims, and then just anyone in the general population that's experienced trauma. I'd like to see how effective psilocybin uh, therapies are for treating the general population as well. As far as the conclusion goes, given my personal experience, I know how difficult it can be for first responders and veterans, one, to seek help, and then two, to potentially even be receptive to the help. It is difficult to get buy-in. I've seen it time and time again. They force fed us all the suicide talks when I was in the Marine Corps, uh, and very poorly. Usually is more accusatory, saying there's always signs. You should have seen this. You should have said something. When we'd lose Marines to suicide, which as an officer I found infuriating that anyone in staff would point the finger at the Marines that love their brother, because sometimes there's just nothing you can do. Kind of a side note there, though. But regardless, sometimes it is very difficult to get that buy-in from veterans and first responders. Why I believe the psilocybin assisted therapies are going to be effective is because of that openness component, that openness and that connectedness that psilocybin has been shown to increase in those who've used it. That openness, I believe, is going to make the cognitive it's going to enhance that cognitive behavioral therapy. Cognitive behavioral therapy is great, but if the person's not going to be receptive to it, it's a moot point. It doesn't matter. So if that psilocybin can break those barriers down, I expect that we are going to see a significant uh, reduction in PTSD symptoms and potentially PTSD as a whole. And then because psilocybin is a Scheduled One uh, drug, in most states, there's been issues with further studying it, but I expect that we're going to see new and exciting fields of study going forward because states like Oregon and I believe Yeah, it was Oregon and Colorado, and then California and a few other states actually have bills in the works to allow psilocybin to be authorized for medical interventions. So we're going to see that Schedule 1 change, probably drop it to like Schedule 2 or so, at which point we're going to see it's going to be easier to conduct these studies, and then hopefully we'll see a greater prevalence of these studies. Uh, for that end goal of treating PTSD at this point for this research in first responders and veterans, but going forward, hopefully for the general population. The next two slides are my references. You can take a screenshot of it, or I guess I'll be posting this anyway, and you can take a look at that. And the second slide of that. Anyway, that concludes my presentation for my research proposal. Let me emphasize that it was the rough draft and the initial run through, and then the technical difficulties for getting it run. This isn't my house. I'm actually on vacation up in Tahoe, and I have to work on this when my kids are asleep. So anyway, thank you for bearing with me through this. I look forward to seeing the feedback, mostly maybe rehearse more and actually know what you're talking about. Granted, yes, I agree. And then in particular, am looking for better feedback or more feedback on the uh, analysis of choice. As far as actually getting the data, I think I got my head wrapped around that. But what is the best way to differentiate between I know it's within subjects for pre, post, and 12-month follow up within those two groups, the psilocybin assisted therapies and the control group. But is my assessment correct, or is there a better form of analysis that can really show me the variance between those two and whether or not one is more effective than the other? Thank you for your time.